Once you have diagnosed a person to be suffering from central retinal artery occlusion or branch retinal artery occlusion, what are the particular tests that can be run on that particular patient that is going to basically make the definitive diagnosis more clearer, or the situation more clearer in that patient? Even the treatment modalities are going to rely upon these specific tests that are going to be performed on these particular patients who are basically suffering from the central retinal artery occlusion in this particular case. So basically, ophthalmoscopy is going to highlight the fact that the person is suffering from central retinal artery occlusion. But on ophthalmoscopy, you cannot visualize the artery or the blockage itself. So there are some particular tests that can be performed in this particular case just to visualize whether, to what an extent this blockage is present in that particular patient. The guidelines are discussed over here, and then we're going to discuss the findings in that particular patient. And then finally, some of the tests that can be run along with this patient evaluation that will be discussed over here. Some of the notorious tests are the OCTs, and then we have the FFAs, that is the fluorescent techniques that can be performed. We have the immunofluorescence techniques, and then we have the visual fields that can be evaluated in this particular case of the central retinal artery occlusion. So over here, there are particular guidelines that are followed by the clinicians that we'll be discussing. Leading cause of death of the cardiovascular disease, and you have to basically refer the person to an ophthalmologist. If you are a family physician, you have diagnosed the central retinal artery occlusion, you're going to further refer the patient to an ophthalmologist particularly. And then referring them for the prophylactic medical or the surgical treatment is again very important over here. Obviously, the ophthalmologist and the team of ophthalmologists is going to decide whether it is a medical treatment that is more suggestive in this particular case, or either a surgical treatment. For example, paracentesis has to be sought out in this particular case, and then the neurological findings are also going to be noted down in this particular case. The fundoscopic findings, the optic nerve is acutely edematous in this case. In these cases of central retinal artery occlusion, the cherry red spots are quite frequently seen. Then we have an optic disc that is more of a pallor kind and more edematous. The associated anterior ischemic optic neuropathy is also noted down in this particular case. The cilioretinal collaterals are also noted down in this particular case. The compensatory enlargement of the capillary anastomosis, that is basically the retinal artery accentuations, they are noted down on the fundoscopic findings. The findings are optic atrophy. On ophthalmoscopy, we are particularly talking about the ophthalmoscopy almost in 91% of the patients, optic atrophy is going to be noted down, and then 58% of the patients, retinal artery accentuation is noted down. In 18%, cilioretinal collaterals are noted down, and then we have the macular RPEs, that is the rapid proliferative techniques are basically noted down, or the rapid proliferations of the arteries are noted down. That is basically a neovascularization in almost 11% of the patients. Then we have the cotton wool spots in almost 3% of the patients. The different techniques that are used, for example, we have the OCTs. The acute stage shows an irregular macular contour with increased reflectivity of the inner retina. So usually it's basically an ultrasound that is performed, and these are some of the pulses that are noted down on the ultrasound. The short pulses use time to distinguish the depth on the ultrasound, and that is basically the light is going to reflect from every boundary. This is a normal incidence, and this is the different variations of the incidences that are noted down, and the mean is basically different in different cases. Different formulas are devised for this purpose, for this technique of the OCT that is devised, helpful in cases of the chronic CRAOs where the fundus may appear featureless in these cases. Then there are some of the techniques which are known as the FFAs in a lot of patients. The residual retinal circulation with delayed and sluggish filling of the retinal vasculature. So due to this sluggish appearance of the retinal vasculature, there was this box scarring appearance or that cattle trucking phenomena that was seen in the retinal vasculature, and that is going to be highlighted on FFAs. Areas of delayed choroidal perfusions are seen, leakage of fluorescein dye at the level of the RPEs. That is also noted down in these particular cases. Then we have other techniques which are known as the ERGs. We have the scotopic blue appearances, then we have the scotopic red, scotopic white, and the 30 Hertz flicker, and then we have the photopic whites. We are basically comparing this normal eye with the eye of the retinitis pigmentosa in this particular case over here. More severe accentuation of the B wave. So usually when these ERGs are carried out on the patients, there are different waves that are basically compared with the normal eye. And the severity of the accentuation of the B wave is more than in the A wave. Since the inner retinal layers are more affected in this particular case, diminution of the A wave and the B wave is also noted down in a lot of cases. And when we have the autofluorescence that is performed, the dye which is usually used is the anti-CD90 that is used, and that is basically highlighting the retinal artery or the ophthalmic artery in this particular case, imaging in the area supplied by the occluded retinal artery acutely. Decreased autofluorescence is noted down in any artery if it is occluded or if it is partially or completely blocked due to the formation of a thrombus, blockage of a normal autofluorescence of the RPE by a thickened inner retina that is observed in these particular cases. Now, when we have a look at the visual fields, the central scotoma is most common defect that is seen in these individuals. Then we have a paracentral scotoma, patients with the cilioretinal sparing. They show a preserved central island of vision, that is basically the central vision is spared, and the peripheral vision is mostly affected in these patients. The treatment guideline, usually you place the patient in a supine position. The ocular massage is one of the treatment modalities. Sublingual isosorbide dinitrate is one of the treatment modality. Then we have the intravenous acetazolamide that is administered. Intravenous mannitol or oral glycerol is sometimes administered. Anterior chamber paracentesis is performed in a lot of patients just to treat any occlusion of the arteries that is present in this particular case. And then we have the intravenous methylprednisolone that is given. We have streptokinase just as a blood thinning agent. It can be administered in these patients. So in this section, basically, we briefly discussed how are we going to evaluate what are the different other techniques that are devised in a patient of a central retinal artery occlusion. For example, FFAs, OCTs, and immunofluorescence techniques that are used just to have a better look at the occlusions or just to have a better look at the blockages and the other treatment modalities that are present widely to treat such patients. So that is the end of this section. Thank you for watching sqadia.com.